Thank you so much for the opportunity to be here. I'm working on developing a safe and effective multi-pronged cell therapy for pancreatic cancer. Nomad 2CR, we're really trying to develop a next generation immunotherapy that will overcome the limitations and the hurdles and the many obstacles that current treatments face for pancreatic cancer. So, how we're doing this is a dual-pronged engineered T cell therapy. So, it's a unique, multi-layered, and adaptable approach. What's necessary, of course, is the antigen-specific T cell receptor, which we engineer into autologous T cells. And this T cell receptor recognizes a specific antigen on the tumor cell. However, this is likely insufficient for tumor eradication. This is based on years of our own research as well as others in the field. So we're further engineering these T cells to express cytokine fusion protein that we're optimizing the lab and that we're developing to recruit other immune cells, engage host immune response, remodel the suppressive tumor microenvironment, and then allow for a more durable approach. Nomad TCR has world-class scientific leadership. I have over 30 years in T-cell immunology experience and over 15 years in pancreatic cancer immunology and immunotherapy. So I'm sure many of you heard about chimeric antigen receptor, CAR T-cell therapies, because they're widely approved for a variety of hematological malignancies, such as leukemia. But to date, there are no approved CAR T-cell therapies for solid tumors, and this is not because people haven't tried. So these are many of the approved therapies currently. And why is this? Well, there's a lot of complexity and challenge to identify unique and safe targets. There's limited infiltration and functional persistence of CAR T cells, and this largely is due to a highly suppressive tumor microenvironment. So T cell receptor-based cell therapies, which is what we're doing, are likely to outperform traditional CAR Ts in solid tumors. Why? T cell receptors, first of all, can recognize any type of protein in the cell. They can recognize intracellular targets, where CARs can only recognize cell surface targets. So there's many more potential targets, such as mutations and neoantigens. They're really sensitive. So T cell receptors can recognize one or two molecules on the cell surface of a cell to elicit T cell mediated killing. That is remarkable. When you think about cancer, a lot of times there are not a lot of targets expressed on the surface of the cell for these T cell therapies. A lot of anecdotal studies and initial studies also show that TCR engineered approaches can persist in vivo for many, many years. And if you ask, is there clinical proof of principle for solid tumor rejection in humans using T cells with TCRs? Absolutely. Think of all the patients that are being treated with immune checkpoint blockade. This is activating T cells that express T cell receptors in the body. This is eradicating solid tumors in a lot of settings. In CARs, there's fewer potential targets. Antigens are limited to those on the cell surface. They're less sensitive. Think of the poster child of CD19. There's thousands of molecules, hundreds of thousands of molecules of CD19 on the surface of a B cell leukemia. CARs are just not as sensitive to TCRs to low expressed targets. In some cases, CARs don't persist. And if you ask, is there clinical proof of principle for solid tumor rejection? No. So we're at the forefront of TCR-based cell therapy approval for solid tumors. Recently, there have been a couple of FDA approvals. One is a tumor TIL therapy in advanced melanoma, and another is a TCR-engineered T cell therapy targeting the cancer testis antigen MAGE-A4 for synovial sarcoma. However, there's a lot of efforts right now to generate TIL therapy for other solid tumors, as well as other targets in addition to MAGE-A4, including work by ourselves as well. So we're a world-class scientific team. We're in a pre-seed funding stage. So I'm one of the founders, and I received a PhD in immunology in 2007. I did my postdoc with Phil Greenberg, a pioneer of adoptive T cell therapy and TCR engineered cell therapy for 8 years, where we developed the first in-human TCR engineered T cell therapy for pancreatic cancer. I'm now an associate professor in the Center for Immunology at the University of Minnesota. Carolyn Lone Tree is a third-year student in my lab. She is in multiple gene editing papers, highly sophisticated technical scientist, highly creative, and her thesis is focused on these regulatable cytokine fusion proteins. So we're working on pancreatic ductal adenocarcinoma, or PDAC. This is the most common and most lethal form of pancreatic cancer. It is the third leading cause of cancer-related mortality in the U.S., 13% 5-year overall survival. Over 60,000 patients will be diagnosed this year in the US, and over 50,000 will die. The average age is 70, and most of those patients that are diagnosed have unresectable, surgically inoperable disease and have less than a year to live. Chemotherapy is the standard of care in this setting, and it's highly toxic, very little benefit, and in a lot of sense, it's palliative. Now, even if you look at patients that have surgery, right, the lucky ones with pancreatic cancer, 10 to 20% of those patients at diagnosis, only 25% will be alive after 5 years. And why is that? Because this disease metastasizes early. Even when you think it's stage 2, it's not. It's already gone to elsewhere in the body. And this is why a T cell therapy actually has a chance. Now, oncogenic KRAS inhibitors are coming online, but resistance is rapid. So there are few classes of therapeutic alternatives that are likely to succeed. This is a table that was put together by the University of Minnesota Venture Center. You can see that TCR therapy, these are expensive therapies, but they're also likely to work. There is restriction to HLA. There's obviously a lot of regulation and hurdles that we have to overcome, but if it works, it's possible. Whereas checkpoint blockade inhibitors, they're not approved for PDA, pancreatic cancer. They work in other cancers, but they don't work in pancreatic cancer. Vaccines, you might have heard about some really splashy, high-profile neoantigen vaccine papers. Well, those have been done in pancreatic cancer in those patients that have resectable disease, right? So we're not targeting that type of cancer, that type of disease. We're targeting locally advanced or metastatic pancreatic cancer. And our TCR T cell therapies, if you think about, can be combined with checkpoint or could be combined with vaccines to amplify the benefit as we go on over time. So NOMAD TCR addresses 3 key failure points for previous therapies. The problem, publicly available animal models, which I'm sure you know, do not adequately represent this complexity of the human disease, leading to clinical failures. Well, we have state-of-the-art pancreatic cancer mouse animal models that our lab developed that are unique to the lab, so we can study, redesign, adapt, and be flexible in our approach. Now, prior therapies focused on obtaining the highest affinity TCRs, but our work suggests this is not the right approach. So our approach is to obtain highly effective tumor-reactive TCRs using novel methods that are not biased towards the highest affinity binders. Finally, therapeutic T cells are likely to need an extra boost to sustain activity in solid tumors. And so our lab is poised to further engineer T cells to express novel regulatable cytokine fusion proteins where we're showing early efficacy in preclinical models. So obviously, pancreatic cancer is clearly an unmet medical need. There's no curative or durable treatments. The total global addressable market is $140 billion globally. And I just want to point this out that there is growth to be expected in T cell therapies from 2023 to 2035, an estimated increase of $4.1 billion and a compound annual growth rate of 51%. So this rapid growth suggests an increasing focus on novel T cell-based therapies to treat solid tumors. There are other companies that are working in this space, far fewer than CAR T cell approaches, but there are TCR approaches, and some have been FDA approved, such as MAGE-A4. People are targeting PRAME, GP100 in melanoma, mesothelin, which is a target in pancreatic cancer, which we have TCRs against, are also all therapeutics that are interested in this space. But we're really focused on pancreatic cancer, and I think that's where we're going to stand out. So cell therapies are popular targets for mergers and acquisitions. And this is, again, analysis by the University of Minnesota Venture Center, where partnerships have taken a big lead. Big pharma seeks to expand pipelines and mid-market public volatility. And strategic partnerships, co-development deals, licensings are soft exits that we plan to pursue. So what is the ask? Well, NOMAD dual-pronged TCR development plan is very early on, but we do have a plan for a rapid path to the clinic. Our ask is we're currently raising $1 million, and this will allow us to have $250,000 for TCR selection and prioritization over the next year and a half, and at the same time, cytokine fusion protein selection and prioritization. And after that, we will be working to obtain a GMP lentiviral vector IND enabling studies and IRB approval, and then hopefully have a phase 1 clinical trial out of the University of Minnesota in unresectable pancreatic cancer. So I'd like to thank you, Equalize, and my mentor, Shelley Forrest Aldred, who's been phenomenal.